Today we are going to talk about the spinal tumors. Generally speaking, there are three subdivisions of spinal tumors depending on their location. First of all is the intramedullary type, which is found inside the spinal cord substance causing expansion of the spinal cord, and the extramedullary intradural type, which is outside the spinal cord but within the dural sac, causing spinal cord compression, and it usually have a wide dural base with the dural tail or the dural cleft sign. And finally, and the last type is the extradural, which is the most common type and related to the bony structure of the vertebrae. The first type is the intramedullary, and the most common of them is the epidymoma, which is the most common intramedullary spinal cord tumor in the adults, representing 60% of the intramedullary tumors in this age group, and the second most common type in pediatrics. It's usually WHO grade 2 or grade 3. It could be associated with neurofibromatosis type 2, especially if it was multiple epidermomas. The most common site is the cervical, followed by the thoracic region. The characteristic feature well circumscribed and well defined. Sometimes they said that it's encapsulated. It's usually found centrally within the spinal cord, causing symmetrical cord expansion. It's associated with peritumoral edema in 60% and polar cyst, whether cranial or caudal, in 60%, and sometimes it's associated with intratumoral cyst. One of the characteristic features of the epidymoma seen in 25% of this tumor is the hemosiderin cup sign due to the internal hemorrhage of the epidymoma. Calcification is uncommon, and this in contrast with the intracranial epidymoma, which was associated with calcification in a considerable proportion. According to the enhancement, it's usually strongly enhanced, but the pattern is variable. It could be homogeneous or heterogeneous depending on the presence of hemorrhage. Epidymoma, and because it's low grade tumor, it's usually slow growing, so it's associated with bony remodeling, including scalloping of the vertebrae and other bony modifications. This is a picture for epidymoma. In T1, it could be iso to hypo. In T2, it's usually hyper and associated with the significant cord edema and the polar cyst, which, as we said, could be cranial or caudal. In this view, in this picture, in this slide, it's caudal polar cyst. According to the enhancement, that in this slide, it takes homogeneous enhancement. This is another view for the epidymoma. Iso to hypo in T1, hyper in T2, associated with the edema, and this is the hemosiderin cup sign, which, as we said, is due to the hemorrhage. And here it's also strong homogeneous enhancement. This is an axial view for the epidymoma, showing the central location of the epidymoma and the symmetrical cord expansion. T1, T2, and the contrast. There's a special type of epidymoma called the Mixo papillary epidymoma. This is seen in adults. It's WHO grade 2, and the special location is within the conus medullaris or the filum terminale of the spinal cord. Also, it's well circumscribed. It could be small and oval in shape, displacing the nerve roots of the coda-equina region, or it could be large and sausage-shaped, compressing the nerve roots. T2 as the normal epidymoma, iso or hypo, but it contains hyper components due to the myxoid or the mucoid components of this tumor. T2 hemosiderin cup sign and hemorrhage is also could be seen, and it could be associated with superficial cirrhosis due to the subarachnoid hemorrhage and iron deposition within the dura and pia mater. Calcification is common, unlike the normal ependymoma, and the enhancement could be homogeneous except the sites of the tumor containing blood. It also could be associated with CSF seeding and could be seen multiple. In children, it could be locally aggressive, causing sacral bone destruction. This is a view of the myxopapillary ependymoma. Here it's showing the bony remodeling of the vertebrae and the posterior scalloping. This is T1, this is T2, and this is the internal hemorrhage within this tumor. And here, after the enhancement, here it takes strong heterogeneous enhancement except the sites where there is hemorrhage. This is another view of the myxopapillary ependymoma, iso in T1 and hyper in T2 with the strong enhancement after contrast. This is a small ependymoma, oval in shape. Still, this is hyper in T1, as we said, because it contains myxoid components or mucus components. Hyper in T2, and here it takes homogeneous, strong enhancement. The second most common intramedullary tumor is the astrocytoma. Astrocytoma represents the most common type in pediatrics and the second most common type in adults after the ependymoma. It could be multiple and associated with neurofibromatosis type 1. Generally, it's WHO grade 1 or 2 in the majority of the tumor. The most common site is thoracic, followed by cervical, and it could present with hollow cord involvement, especially in pediatrics. The most striking feature opposite to the ependymoma is the poor definition of this tumor, and this is associated with a worse prognosis because it's difficult to remove completely by surgery. Location is eccentric in relation to the spinal cord. Edema also could be associated, but to a lesser percentage than ependymoma. Also, we are talking about the tumoral cyst and the polar cranial or caudal cyst. Hemorrhage is uncommon, and this is also in contrast to ependymoma. Enhancement is not strong like the ependymoma and could be patchy. Bony remodeling is less common because, as we said, this tumor is more aggressive than ependymoma and it's usually poorly defined. This is ependymoma in T1. It's not very clear. In T2, it's more obvious, associated with the cord edema, obvious, and after enhancement, parts of the tumor takes enhancement and parts are not associated with the enhancement. This is pattern called patchy enhancement. This is central location, the eccentric location of the ependymoma, showing the compression of the eccentrically displaced cord. This is in contrast to ependymoma. Another view for the astrocytoma, T1, T2, and after the enhancement. This portion of the tumor not take enhancement. The third most common intramedullary tumor is hemangioblastoma. Hemangioblastoma is intramedullary in 60%, intradural in 21%, and could be extradural in 8%. 2/3 of the cases are sporadic, and 1/3 of them is associated with von Hippel-Lindau. And in these cases, the presentation is earlier and usually multiple tumors. WHO grade 1, most common site is thoracic, followed by the cervical. Location is eccentric in relation to the cord and could be associated with exophytic components, and these components are directed toward the cord dorsa. Peritumoral edema and tumoral cysts are common. T1 could be hyper, depending on the vascular components and the blood components found within the tumor. T2 hemosiderin cup sign also is common with flow void signals in large lesions more than 2.5 cm, avidly enhancing nodules after contrast, and angiography could also be used to show the dilated feeding arteries and draining veins. This is a view of for hemangioblastoma, showing the flow void signals and the associated cord edema. This is T2, also showing the flow void signal within this hypervascular tumor and the avid or strong intense enhancement after contrast. Another case of hemangioblastoma, T2, this is the flow void signals, and this is a cranial polar cyst and also cord edema, and this is after contrast. Ganglioglioma. Ganglioglioma is a intramedullary tumor usually seen in pediatrics and represent 15% of the intramedullary tumor in this age group. WHO grade 1 or 2, most common site is cervical, followed by the thoracic region. It could extend over more than 8 vertebral segments, and this is a characteristic feature for ganglioglioma. Location relation to the cord is eccentric. Tumoral cyst found in half of the cases. The characteristic feature of ganglioglioma is the mixed signal in T1 due to the dual cellularity, because it contains gangliocytes and glial cells. Calcification is common, and calcification is pathognomonic for ganglioglioma in these cases. Enhancement could be patchy, and 50% of the ganglioglioma does not enhance. Bone remodeling also is common. This is ganglioglioma extending over a considerable length of vertebrae and associated with polar cyst and cord edema. This is the T2 showing low signal in T2. Some areas, these areas of low signal in T2 could be calcification, and this can be appreciated in CT. And this is picture after contrast showing the heterogeneous or patchy enhancement of the ganglioglioma. Another view for the ganglioglioma in T2 and after contrast enhancement. Usually, it does not take a lot of enhancement and could not take enhancement in, as we said, 15% of the cases. Intradural extramedullary tumors. First of all, we are going to talk about the nerve sheath tumors, starting with the schwannoma. Schwannoma is the most common nerve sheath tumor, representing 65% of the cases, and could be associated with the neurofibromatosis type 2 in 35% of the cases. Shape is round. Location is usually anterior and eccentric, displacing the nerve root. T2 could be mixed signal depending on the presence of hemorrhage, cystic degeneration, or fatty degeneration. Calcification is rare. Bone remodeling is common because it's usually benign tumor and causing widening of the neural exit foramina. The typical dumbbell shape for schwannoma is seen only in 5% of the cases. This is CT showing the schwannoma and the bone remodeling with the dumbbell-shaped tumor seen in CT. MR T1 showing the dumbbell shape with the intradural and extravertebral components, showing the dumbbell shape seen, as we said, in small percentage of the cases. Here, sites for hemorrhage, and here the after contrast enhancement. Schwannoma here causing posterior scalloping of the vertebrae in T2 and T1 here stir and here after contrast. Another view for the schwannoma, here associated with hemorrhage, and the hemorrhage does not take contrast. So hemorrhage is a clue for schwannoma, while as we'll see in neurofibroma, target sign is a clue for the neurofibroma. T1 and here after contrast showing the internal hemorrhage of the tumor. Neurofibroma represent 35% of the nerve sheath tumors. It's benign as schwannoma could be associated with the neurofibromatosis type 1 in 35 of the percent. Shape is usually fusiform, anterior location, centrally encasing the nerve root. This is in contrast to the schwannoma, which is usually eccentric. T2 target sign could be seen in neurofibroma, and calcification is rare. Bone remodeling is common and also causing widening of the neural exit foramina. This is a case of a neurofibroma, T1, T2, and after contrast. This is the target sign for a neurofibroma, which is, if we see it, this is a clue. So we can say this is a neurofibroma in contrast to schwannoma, which, as we said, usually come with hemorrhage. This is a case of a neurofibromatosis, multiple neurofibromas, multiple target signs, neurofibromatosis type 1. Coronal view, T1 and T2 for in neurofibroma, neurofibromatosis type 1, multiple neurofibromas. Meningioma. Meningioma, 30% of the intradural tumors. Old age female usually is the presentation. WHO grade 1 or 2 could be associated with neurofibromatosis type 2 if it's multiple and in pediatric age group. Thoracic site is common, most common, followed by the cervical. Well circumscribed, lateral to the cord or posterolateral, and the most important feature is the broad dural base and the dural tail sign, which is seen in 65% of the cases. Calcification is associated with 5% of the tumor. Enhancement is homogeneous and diffusion is restricted. This is also a characteristic feature for meningioma. This is a case of meningioma, T1, T2, and the wide dural base with the homogeneous enhancement and the dural tail sign, which is, as we said, seen in more than half of the cases. Homogeneous enhancement also. T1, T2 with the wide dural base and homogeneous enhancement, homogeneously enhancing a tumor. Wide dural base, T1, T2, and the homogeneous enhancement. Paraganglioma. Paraganglioma have a wide age range of presentation, could be seen in pediatric age group and also in old age. The location is within the filum terminale and the coda equina region. The most common site for the paragangliomas, as we know, is the adrenals and the head or neck region. The presentation within the spine is rare. It's WHO grade 1. It's well circumscribed tumor and have a characteristic T2 salt and hyper and hypo regions, and the hemosiderine cup sign, because it's a hypervascular tumor. So also it could be associated with hemorrhage and the hemosiderine cup enhancement. The hemosiderine cup sign. Regarding the enhancement, it takes intense enhancement because it's a hypervascular tumor. This is a case of paraganglioma within the coda equina region. T1 causing also bone remodeling, posterior scalloping, causes a low-grade tumor. T2 after contrast enhancement. It could be associated with the flow void signals, as in this case. This is the flow void signal within the paraganglioma and the hemosiderine cup sign. Some tumors could be mixed, having intramedullary and intradural components like metastasis. First, we are going to talk about the intramedullary metastasis. Presentation usually in old age. The most common primary is the lung, representing 50% of the cases, followed by the breast, lymphoma, leukemia, or melanoma. Most common site is cervical, followed by the thoracic and the lumbar lesion. Solitary in most of the cases, extending over 2 to 3 vertebral segments, well-defined, causing cord expansion, and the striking feature is the disproportionate peritumoral edema, avidly enhancing or could present with rim sign or flame sign, representing hyperdense areas extending from the tumor cranially or caudally. This is the flame sign. This is solitary intramedullary metastasis. T2 showing the disproportionate edema within the cord region and taking rim enhancement after contrast. This is multiple metastasis, multiple enhancing nodules, and disproportionate cord edema visible or clearly seen in the T2. Intradural metastasis. The most common primary in the pediatric age group is the CNS tumors, Astrocytoma, epidermoma, or the primitive neuroendocrine tumor. And in the adults, the most common primary is from the lung, breast, melanoma, lymphoma, or leukemia. Site is usually lumbosacral. MRI without contrast could be normal, and after contrast, it could be seen as multiple enhancing nodules or the diffuse leptomeningeal enhancement called the sugar coating. This is in T1, not obvious. T2, not obvious. And after enhancement, we can see that there is enhancement of the leptomeninges. This is called the sugar coating. The same thing, T1 and T2, not obvious. And after enhancement, there is enhancement of the leptomeninges. This is a magnified view to show the enhancement of the leptomeninges, as we said, called the sugar coating sign, and it's an indication for intradural metastasis. Lymphoma, intramedullary lymphoma. Lymphoma could be extradural, and this is the case in most of the lymphomas, and could be intradural or intramedullary. Presentation is usually middle-aged female. 85% of the cases are non-Hodgkin's. Site is cervical, most commonly, followed by thoracic and lumbar. Most of the cases are solitary. The mass is poorly defined with homogeneous enhancement, and with diffusion, it's restricted. This is a lymphoma homogeneously enhancing after contrast. Also, this is a case of homogeneously enhancing lymphoma. Well defined and homogeneously enhancing. This is intradural lymphoma within the coda equina region, associated with thickening of the nerve roots and the enhancement of the filum terminale of the spinal cord. Solitary fibrous tumor. Solitary fibrous tumor is intramedullary in most of the cases, or could be intradural. It's well circumscribed benign tumor, and the characteristic feature is that it's hypo in T2 due to the presence of the collagen fibers. It takes homogeneous enhancement. This is the characteristic for the solitary fibrous tumor, is that it presents with T2 low signal due to the presence of collagen fibers, and also it takes enhancement. Non-neoplastic masses. First, we are going to talk about the arachnoid cyst. It could present at any age, could be intradural or extradural. It could be primary, and in these cases, most of the cases will present in the thoracic region, followed by the cervical, and it could be secondary to trauma, inflammation, surgery, or lumbar puncture. And in these cases, it could present in any region of the spinal cord. Arachnoid cyst is not identified unless it causes cord displacement. It takes no enhancement and free diffusion. So we only depend on the cord displacement, seeing a cystic lesion causing cord displacement and taking no enhancement. Causing cord displacement and takes no enhancement. High on T2, cystic lesion without any solid component and take no enhancement. Epidermoid cyst. Epidermoid cyst usually presents in patients older than 20 years. Its intramedullary presentation is rare, acquired in most cases due to lumbar puncture. This is in contrast to the intracranial epidermoid. Usually it's well defined, no surrounding edema, hyper on flare, no enhancement or thin rim with restricted diffusion, and hypo on ADC map. This is epidermoid on T2. This is also an epidermoid on T2, showing hyper T2 and takes enhancement. Dermoid cyst presents in patients younger than 20, extramedullary in 60% of the cases, and intramedullary in 40% of the cases. Location is usually lumbosacral or coda equina region. Well defined. T1 contain hypo components representing the water and hyper components representing the fat. Flare, hyper, and takes no enhancement with diffusion restricted, and hypo on ADC map. Calcification could be seen in the dermoid. So we can differentiate it from the epidermoid depending on the presence of calcification or fat. This is on T2, mixed signal, and takes usually no enhancement. This is T1, this is T2 with mixed signal, and after contrast, it takes no enhancement. Intradural lipoma. This is lipoma, hypodense on CT. Lipoma could be associated with spinal dystrophism, and this is the most cases with lipomyelomeniingocele, or could be intradural, and this is the case in 4%, or within the filum terminale in 12% of the cases. Presentation is young age, second or third decade, thoracic most common site, followed by the cervical. It's well circumscribed. T1 hyper takes no enhancement, and then after fat suppression technique, it looks hypo. Hyper on T1, this is lipoma of the filum terminale, hyper T2, and hypo after fat SAD technique. T1 hyper, T2 hyper, and takes no enhancement.
شكرا جزيلا دكتور